This year we focused on analyzing role of CPD in differentiating megaloblastic anemia from the rest of the anemia. To understand little bit about CPD, let's revisit Mindray 3D SF cube graphics. Basically, the cube is generated based on data gathered in these three detectors, two scatters and one fluorescence. The forward scatter, which measures the in vitro size of the cell, is plotted along the z-axis. The side scatter, which is plotted along the x-axis, it represents the internal cellular complexities like granularity, nuclear segmentation, etc. And finally, the nucleic acid content, which is the marker of immaturity, or that is plotted along the y-axis and is measured by fluorescence. Now, what is additional in some of the newer analyzers like 68 Plus and 700 series instrument, they provide the mean value of the clusters along the x, y and z coordinate. For example, in the first scatter, if we see the nu x is having the value of 348. That means the mean of the neutrophilic cluster is lying at the distance of 348 along the x-axis. Nu y 409 means the mean of the neutrophilic cluster is lying at the distance of 409, and nu z 1731 means the mean of the cluster is lying at the distance of 1731. Now, any disease which cause or which induce morphological change in the cluster sufficient enough to change its position in the three-dimensional cube will alter the cell population data. Now, to evaluate role of CPD, we divided our study into two groups. One is anemia group and another is without anemia. In anemia group, we primarily focused on differentiating megaloblastic from the other anemia like non-megaloblastic macrocytic anemia and few other anemias. The diagnosis of all the cases were confirmed through necessary investigation. To assess the role of CPD in isolated B12 deficiency or latent B12 deficiency, we compared data from patients with normal B12 level with the B12 deficient subjects. We further divided B12 deficient subjects into mildly deficient, moderately deficient and severely deficient individual. To establish reference range, we took 165 health check patient whose clinical, immunological and biochemical parameters were within reference range. Now, this is a classic megaloblastic anemia on Mindray 68 Plus analyzer with RBC histogram and a few scatter plots. The upper part is from a normal subject and the lower part is from classical megaloblastic anemia. We all are well versed with the analyzer data of megaloblastic anemia like macrocytosis, usually 100 and above 110 femtoliter, high RDW both CV and SD, low RBC count, RPI less than 2, high RHE, IRF is usually high. The additional RBC VHF plot, that is typically show elongation in the vertical elongation in the middle zone with retics being occupied in the uppermost part. Now, in the WBC scatter plot, here we can compare the neutrophilic cluster from a normal subject to the megaloblastic anemia. Here we can see the slight shifting of this neutrophilic cluster along the x-axis. So, we can expect that the nu x, which is the marker of cellular internal complexity, would be high in the megaloblastic anemia group. Now, our focus was only on cell population data. So, we compared all 9 CPD parameters, that is neutrophilic, monocytic and lymphocytic. To find correlation, we use receiver operating characteristic curve with calculated area under curve. The area under curve actually quantifies the overall diagnostic accuracy, like AUC near 1 is considered as perfect classifier. AUC near 5 does not have any statistical significance. So we used 0.7 as cutoff for the parameter selection. Out of all 9 CPD, neutrophil and monocytes, as we can see in this rock curve, neutrophils and monocytes parameters showed AUC above 0.7, while none of the lymphocytic parameters showed any correlation. We did further statistical analysis of these 6 parameters. In the upper part, we can see in this box plot, the first one is of megaloblastic anemia group, the second one is of non-megaloblastic macrocytic anemia group. We can see the clear-cut demarcation or differentiation between these two groups. And in megaloblastic anemia group, almost all the parameters they showed increased values, increased cell population data value. In the lower two rows, they are shows the mean and the standard deviation of each of the parameter. The third row shows the data from the control group with study reference range of 95% confidence interval, and the last row shows the p values that is way below 0.05, indicating overwhelming significant statistical difference. Now, based on the Yoden index, which combines both sensitivity and specificity, we calculated optimal cutoff point for each of the parameters so that we can minimize both false positives and false negatives. For example, at the cutoff of 4 to 8, 4 to 4, nu X alone could have diagnosed 93 out of 108 cases of megaloblastic anemia. But at the same time, it could have misclassified 16 cases from non-megaloblastic anemia group as megaloblastic anemia. The overall performance matrix was above 85%. The rest of the other parameters, they showed a little bit of less significance, statistical significance. So if I have to summarize the statistical performance of all the 6 parameters, I would say that nu X, that is the marker of neutrophilic internal complexity, was the best correlating parameter, followed by the neutrophil size, in vitro size. Then comes the monocyte nucleic acid content, followed by neutrophil nucleic acid content, and lastly monocyte internal complexity, and lastly the monocyte size. Now, to improve the prediction accuracy, we used logistic regression analysis, which is also known as logit model. We combine all 6 parameters because each and every parameter was associated with many false positives and false negatives. Logistic regression estimates probability that a given case belongs to one group or other. The output of the equation is always between 0 and 1. 0 means likelihood of the disease is minimal, while 1 means the highest probability of the disease. In our study, we combined all 6 correlating parameters which operated independently, and logit equation was created. We called it as megaloblastic anemia prediction score, or logit CPD. We evaluated its utility in the megaloblastic anemia differentiating from non-megaloblastic macrocytic anemia, and we got significantly improved area under curve, that is 0.991. At the cutoff of 0.6, we got much improved performance metrics, the sensitivity, specificity, positive predictive, negative predictive, and accuracy above 95%. With only 5 false negatives and 5 false positives in each of the group. The same can be seen visually in this box plot. This particular graph compares the 6 CPD parameters and the performance of the logistic regression analysis equation. And here we can see the at least this logit equation has improved the diagnostic accuracy by 10%. We also tried to analyze the utility of this logit equation in differentiating megaloblastic from other common anemias, and the results were even better with AUC of 0.995. With the false positive in each of these category, like anemia of chronic disease, CKD, anemia associated with CKD, iron deficiency, and beta thalassemia trait. These are the number of cases which we studied, and the false positives were below 2%. We also wanted to investigate whether vitamin B12 deficiency alone without anemia or without hematological manifestations can cause statistically significant change in the CPD parameters or not, and the answer we got was no. Here these are the groups with non-anemic subjects, and this is classical megaloblastic anemia group. First three boxes are from the severely deficient, mildly deficient, and moderately deficient and mildly deficient B12 group without anemia, and the last one is with the normal B12 levels without anemia. So B12 deficiency alone is not a reason to cause change in the cell population data. Now lastly, let's see some of the examples, real-time examples. This is an example of 35-year male patient presented with classical megaloblastic anemia. The table shows his CBC data on the day 1, day 3, day 7, and lastly after 3 weeks. The lower part graph we can see as the treatment progressed, all 6 CPD parameters gradually started returning to the baseline level. In the table, the last column is of logit or logit equation or megaloblastic prediction score. Initially it was near 1, and as the treatment is successful, as the hemoglobin reached to normal level, it also reached to almost 0. These are a few more examples where after successful treatment of megaloblastic anemia, as hematological parameters improved, CPD also returned to their baseline level, and so the logit equation also decreased, reaching to almost 0 in almost all cases. So to conclude my presentation, the take-home message is CPD alone can be very helpful in suspecting or differentiating megaloblastic anemia from other anemias. If look carefully, we can get help from least expected corner. Like in this case, we suspect megaloblastic anemia just by looking at the objective values of CPD. CPD parameters do not have any role in suspecting or diagnosing B12 deficiency without its hematological manifestation. I recommend further studies needed to validate that part. Another important point is that comprehending so much data that modern day cell analyzers are throwing at us can be very challenging. Subtle changes often go unnoticed, and for that we require help of statistics and data science, and that can really add value in the patient management. And lastly, the combination of parameter enhances correlation, reducing false positives and false negatives associated with each of the parameters. With that, I conclude my presentation. Thank you.